My name's Dr. Rob Murphy. I'm the Executive Director of the Institute for Global Health here, and I'm the John Philip Fair Professor of Infectious Diseases and Professor of Medicine and Biomedical Engineering here at Northwestern's Feinberg School of Medicine. Thank you for taking the time to join us this afternoon for our latest installment of our First Friday Global Health Seminar Series. This one is entitled COVID-19 in Illinois, very local and timely topic. Please take a moment to follow us on Facebook and Twitter, hashtag FSM Global Health. In addition, we welcome you to become an Institute for Global Health member to receive access to specialized resources and services that support research infrastructure. For more information, please visit our website, very simple one, globalhealth.northwestern.edu/members. Today, we're thrilled to have with us Professors Jaline Gerardin and Sarah Cobey for a timely discussion on their work with the state of Illinois that began in March of 2020, in which focused on forecasting the COVID-19 epidemic here and predict upcoming hospital capacity needs and stand up a sentinel surveillance system. First with Jaline. She's an assistant professor in preventive medicine here at Northwestern's Feinberg School of Medicine. In addition to her COVID-19 work, her group works with malaria-endemic countries to develop data-driven national strategic plans to reduce malaria, morbidity, and mortality. Prior to her appointment at Northwestern, Jaline was the malaria lead at the Institute for Disease Modeling in Seattle, Washington. Sarah Cobey is an associate professor in the Department of Ecology and Evolution at the University of Chicago. She runs a computational research group that investigates how the host adaptive immune response coevolves with respiratory pathogens, from the dynamics of individual infections to pandemics. This research involves linking immunology, epidemiology, and virology with ecological and evolutionary principles with the hope it can lead us to better vaccination strategies. There's going to be time for questions following the presentation, which we welcome you to submit your questions through the Q&A feature. The chat function has been disabled, so you have to go through the Q&A at the bottom right-hand corner of your screen. And now, Jaline and Sarah, I turn it over to you. And thank you both for coming.
Thank you, Rob. I'm just going to go ahead and share my screen. Hope technology does not fail us today.
So far, so good.
So far, so good, as you say. All right. So I'm going to start by putting ourselves in the shoes of a decision maker, say, perhaps the governor of Illinois, perhaps the Illinois State Department of Public Health, and asking ourselves, like toward the end of October, as trends were increasing again, wouldn't it be nice if we could see the future and kind of be able to predict, whether occupied beds are going to start going down again, whether they're going to continue to increase, or whether they're going to really shoot up, and perhaps we should prep field hospitals again. Boy, would it be nice to kind of have some idea of what might happen. And that's where the state has kind of turned to our groups to provide some kind of insight on the future. So let's start by doing kind of a brief, quick look in history. In 2020, for us as modelers, a very major event was the mid-March release of the Imperial College model. And they predicted 2.2 million US deaths if no countermeasures were taken. At the time, this was enormous. It was like such a mind-boggling number. Looking back at this a year later, I think they were pretty on the nose. We have about just over 500,000 US deaths, with about a quarter of the US population having experienced COVID. And so, if you multiply 500,000 by 4, you would have gotten 2.2-ish million. So that is pretty kind of amazing to me. So close on the heels of that, Governor Pritzker issued his stay-at-home order to begin on March 21st. And that's where everyone retreated to the cocoons of their homes and where some of us remain. Shortly after that, the governor hired a data consulting firm to landscape the space of models that were currently being used in Illinois to predict trends in Illinois. So at this time, there were quite a lot of models that were kind of in play, both national models and within state models, and even individual hospital systems such as NMH were building models to try to predict what their upcoming kind of needs would be. So CIVIS was hired to kind of to figure out which models were any good, which models were more appropriate for the state needs, and also to coordinate some data access kind of needs across modeling groups. kind of around the same time, I don't know if anyone else remembers this, this is also very memorable for me as a modeler, the IHME released this very, very bad model. This later became the favorite model of the White House, and a lot of time and energy was taken by, I would say, legitimate infectious disease modelers to try to counter the effects of this release. In early April, our modeling task force was assembled. We began meeting. We met daily for a very long time. Now the cadence has really dropped off as the situation has evolved. And we first began releasing our weekly forecasts shortly after that. And at the end of April, Governor Pritzker presented some of the outputs of the task force at a press conference. And this engagement has continued. We're still doing these things, and we'll tell you a little bit about what that looks like.
All right, so the task force is made up of 4 different groups. The first group is Argonne National Laboratory, and this work is really led by Chick Makel and Jonathan Ozick. And their expertise is in these very large-scale agent-based models. And they've been primarily focused on modeling dynamics within Chicago. I, Sarah Cobey, am leading the University of Chicago modeling group, and as mentioned, our background is in infectious disease modeling. Primarily, we focus on influenza, or I should say pre-pandemic, we focused on influenza, and especially understanding how flu evolves, how flu infects different age groups and different seasons, and how the immune responses to flu develop and then shape flu evolution, and the variable effectiveness of flu vaccines in different seasons and different age groups. Jaline, of course, is also an infectious disease modeler, and her primary focus before COVID was malaria transmission modeling, and she has extensive expertise also in interfacing this modeling with policy. And then finally, the fourth group is led by Nigel Goldenfeld and Sergei Maslov from UIUC. And their main training is physics, and they had previously worked on the dynamics and coevolution of microbial ecosystems. And I think this is their first foray into infectious disease modeling. So the topics that we're going to cover today, first, we're going to show you a little bit about what these mechanistic models look like that the different teams have been constructing, and the sort of projections that we've been sending to IDPH and the governor's office on generally weekly cadence. Then we'd like to take a step back and talk more broadly about what has mostly not gone very well, about the pandemic in Illinois. So first, we are going to talk about the first wave, so the disparities in attack rates, access to testing. Then we'll talk about what our reopening looked like and ways that this could have been better, both in terms of the interventions that we could have been prepared to implement, and then also really what we call the situational awareness and ways in which our policies might have adapted or been adapted over time. So that involves RT estimation, sentinel surveillance. Then we're going to talk briefly about vaccination rollout, a little bit about the variants of concern that are emerging, and finally, what it would look like if we were to do things better in the future. All right, so on this topic of weekly forecasts, our basic task here is to come up with some way to predict the incidence of COVID disease in the near term. So all of us came up with what are known as mechanistic models that are trying to represent the basic features of transmission and how people basically turn into hospitalized patients and eventually deaths. So there are lots of different ways to do this. Jaline, over to you.
All right, so the first step is we need a kind of model structure that includes the features that we care about. And from the beginning, the features that the state cared the most about was number of people in beds, so occupied beds, and occupied ICU beds. And early on, also ventilators, so that really became deprioritized as approaches to care really changed. And secondarily, also interested in deaths. So our model here, which I've shown kind of the basic schematic of, includes these compartments for hospitalization and ICU occupancy. It also distinguishes between severe COVID and mild symptomatic COVID, as well as asymptomatic COVID.
All right, so here's an example of our current model. This is the University of Chicago model, and I'm not going to walk you through the details, but we make a few assumptions that are different from what Jaline's group is currently doing. And some of this has to do with the flow of patients within the hospital. And this sort of diversity in what we refer to as like model structure is really, really important, because you don't want your modeling results to fall apart if you just change one assumption in a plausible way. So that's why it's pretty fabulous to have multiple modeling teams like producing these projections every week. And we can also learn a lot about the epidemiological processes by comparing where our models do and don't work. So that's pretty great. So a key step here, of course, is we're not trying to discover the biology of COVID from scratch. So we look into the literature and use all the data that we can get our hands on to parameterize the model. For instance, things like the infection fatality rate or the duration of infectiousness, we don't expect to vary too much around the world, at least initially, for the infection fatality rate. Of course, there are certain attributes of the model that are intrinsically very local, such as like local rates of transmission. Eventually, the hospital fatality rate is really varying over time and by region. So we combine this literature review with, again, like close analysis and inference of some of the local parameters. We take great care not to misinterpret the data, because of course, this is all coming to us very quickly through these systems that are just being set up. I'll show you an example of that in a little bit. And all of this involves really just, drinking from the fire hose.
We're on Twitter a lot, basically. That's
Yeah.
So just to show kind of a simple example of not taking data necessarily at face value. So what I'm showing you here is the weekly COVID-19 attributed deaths that are coming from the Illinois Department of Public Health, that's IDPH. And so if we're looking to parameterize our model, say that very important transmission rate, so how fast is transmission and is it increasing, then we'll be wanting to look at the slopes of these curves of deaths and hospitalizations and things like that. But we need to ask ourselves the question, like, does this pink curve actually contain all of the COVID-19 deaths that happened? Or were there issues with underreporting and underdetection, even of COVID deaths, especially early on in the epidemic? So what we did was we turned to CDC data. CDC is putting out excess select cause deaths. What that is more deaths that happen in 2020 versus previous years, but only not every single cause of death, but just certain ones. Here we've gated on respiratory related deaths. And we can see that the purple curve is higher than the pink curve, which, what does this really mean? Not incredibly clear, but what it suggests is that the COVID-19 attributed deaths that IDPH has in their data set, which is people who tested positive and they later died in a manner that was ascertained as being caused by COVID, that may not have actually captured all the deaths due to COVID that happened. Though, again, we don't know this for sure. This is going to be a little bit subjective, how much of those purple deaths you want to attribute to COVID. And to complicate that a little bit more is that IDPH also is tracking, deaths of people who tested positive for COVID, whether or not that death was actually attributed to COVID on their death certificate or through another means. And while the green curve and the pink curve kind of track together in the early part of the epidemic, suggesting that maybe those excess deaths were really true issues of underdetection, once we're in the fall wave, we're now in a situation where the green curve is closer to the purple curve, which again makes it a little bit hard for us to interpret as non-clinicians, not people who are examining death certificates or patients, to understand like why there is such a discrepancy between these different data sources.
All right, so the next step after basically formulating our hypotheses or our idea of what's going on in this mathematical computational framework and trying to look to the literature for parameters is, especially for some of those local parameters, we need to calibrate or fit the models to the data. So when we're talking about the data that we're using, maybe the first types of data that spring to mind would be something like the fraction of all COVID tests that are positive, or the total number of cases. And these are, initially what a lot of people, are looking at when they're thinking about what the epidemic dynamics are, but we actually don't use them at all. And I think we are in the super majority here of infectious disease modelers in the country. These two metrics are considered just extremely biased, and we don't really understand them all that well because of how testing works in this country. So, so we are not using them to fit the data, though of course we are tracking them because they're very interesting for other reasons, and we'll look at them in a little bit. So instead, what we are fitting or calibrating our models to are hospital admissions with COVID-like illness, beds, ICU and non-ICU that are occupied by COVID patients, and then also COVID deaths with all the complications that Jaline was just reviewing. So what we're doing again is we're taking these different types of data and we are using it to, we're using it to fit things like the transmission rate over time in different regions in Illinois, and estimate like durations, in different parts of the hospital and that sort of thing. So over to you.
I'm controlling the slides, and any goof ups are my fault. So what this looks like for us is we actually model Illinois not at the state level but at the COVID region level. This is an administrative unit that IDPH is using for looking at trends and making mitigation decisions. And what we're trying to do is to have this pink model curve match the gray data curve simultaneously across all these different indicators that we think are reliable. So COVID-like illness admissions, med-surg occupancy, also known as inpatient non-ICU census, ICU occupancy, and deaths. So we can see here, this is like a kind of an okay model fit. In general, we're capturing those trends fairly well. We have the general idea of the slopes. Our model is missing a little bit here and there. And so it's a continual process of refinement to see like, what is it that we don't understand about, say, fraction of people who are admitted, who make it to the ICU, how long they stay in the ICU, how long they stay in med-surg, which it varies a bit from region to region. It varies in time, so it is like a complex process, and we may or may not really have all the data that we need to make a confident decision on this. But this is generally what a calibrated model looks like.
All right, so the main thing that we were producing is not so much insight on past dynamics from week to week, but really some sort of forecast, short-term forecast of what the next couple of weeks might look like. So generally what we have been doing is we have been, inferring the current prevalence, like current transmission rates, and projecting them forward. Occasionally, we've also been playing out like different scenarios, if we assume that shelter in place continues or there's some dramatic change in behavior. What you're looking at here are plots from one of the recent weekly reports that we submitted. We're looking at, daily non-ICU and ICU bed censuses, and you can see the outputs of the Northwestern and UChicago models along with our uncertainty. And we really don't like forecasting more than a couple weeks in advance. All right, so another thing that the models implicitly are producing is an estimate of the reproductive number over time, which I'm sure everyone here has heard of. Again, the critical threshold for the reproductive number, which is the expected number of secondary cases caused by a case at any time. That threshold is 1. So if it's above 1, it means, bad news, the epidemic is growing. If it's below 1, it's shrinking. And there are lots of different ways to estimate the reproductive number that we could talk about in the Q&A if anyone's interested. But the key thing is that our mechanistic models are producing that reproductive number. And then actually we're using complementary approaches too. So we use a lot of different data streams. So this reproductive number is really important, and we're going to be coming back to why I think, or why we think it's deserved a little more attention during our pandemic response. Okay, so the last thing I meant to say about the task force is that, first of all, I think all of the groups, or almost all of the groups, have their code available online. So if you're interested in the models, you can dig into them there. And then also for us, this is effectively like public service. We're not getting paid for any of the work that we've been doing.
Yay. Okay, so now we'll switch gears and ask the question, what went wrong? And to me, this question is really motivated by kind of like a macro look at not just Illinois, but our whole country, and ask like, did we do a good job with COVID? And for me, that answer is just, unambiguously, no, we did not do a good job with COVID. We know it was possible to do a good job with COVID because other countries did it, yet we did not. And everything that we're talking about in this section is definitely not unique to Illinois, probably applies to every state but Hawaii or something like that. So I don't want to seem like we're picking on Illinois, but clearly we know the Illinois context the best. So the examples that we're going to be talking about are from Illinois. So here, what I'm showing you here is the daily death curve. And, I look at this and, that 2-hump structure is really striking. And I ask, was it inevitable that we had this fall hump, given everything that we had already experienced through September, October? Like, was it inevitable that we had so many more deaths happen late in 2020? And then pushing a little bit further and asking, was it actually inevitable that we had that first hump, or were there things that we could have done or been better positioned to do in those early months that would have mitigated a lot of those deaths? And the first thing to really notice about those first deaths is that the disparities were just enormous. What I'm showing you here is the relative risk of COVID mortality for Black and Hispanic Latino populations relative to white for just that first wave. So infections that happen kind of in the March through June timeframe. And what we've done here is we've stratified this by age so that we can look specifically at different age groups. And the relevant comparator line here is actually at 1. So if relative risk is 1, we have the same risk of dying in a Black or Hispanic population versus the white population. And first, we notice that all of these dots are way to the right side of 1. And some of them, even especially for the younger adults and younger individuals, are enormously high, 15 times as likely to have died of COVID if you were Black or Hispanic than if you were white during that first wave. And this is just absolutely enraging. Second thing to note is that access to testing was really not equitable and remains inequitable. We all kind of probably remember back in March and April of last year, it was virtually impossible to access a COVID test unless you were showing up at the ER in respiratory distress. And it's absolutely true that the state has made enormous strides in expanding access to testing since then. Here I'm showing tests per capita, and we can see it's just like completely, different story now versus back, a year ago. But there's different levels of access to testing across these different racial and ethnic groups. And furthermore, in the previous slide, I showed 10 to 15 times higher deaths in Black and Hispanic communities. Do they have 10 to 15 higher access to testing? No, they don't. So, what might appear to be, the same test per capita actually does reflect a disparity in access to testing once you account for burden of disease.
All right, so our models all showed that sheltering in place was having an enormous effect on the reproductive number. My group estimated it cut it by roughly 2/3. And what that means is that, if we had stayed that course, which is obviously a really painful one, but, if we had kept the reproductive number, below 1 for longer, then, containment might have been an option, especially if we had been focusing our testing at importation. So of course, in a country of 50 states, this is not necessarily so practical. So we reopened instead. And at the time, the major mitigations, aside from social distancing and mask wearing, that were being pushed as kind of our tools to manage the pandemic were testing and contact tracing. At the time, it was really clear that testing and contact tracing were not going to be that effective in mitigating the pandemic. So one of the easy back of the envelope calculations you could perform is you could take infection fatality rates estimated, in other countries, and from the deaths, if we assume for, a moment that they're all perfectly reported, you can calculate the expected number, that range of infections that would have been present in the state a couple weeks before. And then you can look at how many cases were being reported over that time interval and calculate the fraction of all infections that were being ascertained or, effectively caught as cases. And we're looking at some estimates of that over time for the state, but it's really clear that when we're talking about, the end of shelter in place, we were maybe like catching, 15% optimistically of all infections. So if we start with the assumption that as soon as somebody is tested that they isolate, then that means optimistically you'll be cutting transmission rates by like 10% or something like that. Again, we're still not capturing most of the people who are transmitting. Of course, there are ways to implement contact tracing so that, this is like more effective, but next slide, please. Another complication that we had was that not only were we not finding most infections, but we were really finding them way too late. So a study I was involved in found that in the summer of 2020, 56% of people who wanted to test in Illinois waited at least 8 days to receive a test result. And we know that most transmission occurs a few days before and a few days after symptom onset. The state, I don't know of any plans to focus on reverse contact tracing, so tracing to the source and then trying to go back and find other people who were at that party or whatever, who were infected. And this is really been the focus in other countries like Japan that have managed to contain COVID. And then we also had, primarily anecdotally, but low compliance with contact tracing, isolation, and quarantine. Many people were not even able to isolate if they wanted to. And so all of this put together, and this frankly was very clear at the time, showed that testing and contact tracing, although important, really could not have been expected to change RT and the transmission rate more than a few percentage points at best, which meant that we were really reopening with our fingers crossed about the impact of social distancing and mask wearing primarily.
And summer weather, perhaps.
Yes, exactly. Thank you. And the weather, yeah.
So if we're not gonna contain very well, then what are our other options? So Sarah and I proposed at the beginning of May that the state use 2 indicators to track its kind of situation. So the first one is RT. So we have ways to infer RT. And again, if RT greater than 1, that's bad news. The epidemic is growing. If RT less than 1, then it's shrinking. So we proposed that we would measure the prevalence of infection in sentinel populations. We'll get back to this and explain in a lot more detail, and then use that to estimate RT. And then rather than having something like, only fewer than 8% of tests come back positive, we would instead say, well, have your indicator be RT above or ideally well below 1 before you take actions that would potentially increase transmission rates, such as, open up indoor dining, et cetera. So that's just one indicator that tells us kind of dynamically what things are doing, whether the epidemic is growing or shrinking. And the other indicator that is also absolutely necessary is kind of like a acceptable burden of COVID metric. So is this, do you have few enough people occupying hospital beds? Do you have few enough people dying that you deem this as acceptable? Because we could think that you could have an acceptable indicator 1 without an acceptable indicator 2. For example, you could have RT at 0.9, but 100 deaths a day, and we would agree that reopening at that point would be a bad idea. So just to talk a little bit more about test positivity rate, because it's such a popular indicator, not just in Illinois, but across the nation, we do not like TPR. So I want to be very clear that that is our stance. We don't like it. We think there are far better, more rigorous indicators that should be used. So I'm going to take you through kind of a thought experiment to illustrate why we think TPR is just so unreliable. And the things to keep in mind is that it's really about the denominator and behavior of people who are coming in for testing, and the fact that we don't actually know who those people are and why. So let's think of this thought experiment where test positivity rate is constant at, say, 20%. And in all 3 of these cartoons, we're seeing a constant TPR through time. But because the volume of testing is changing, that is masking the true state of the epidemic, which itself is actually changing or could be constant. We don't know, because we don't actually know what's going on. And similarly, we could have a situation where TPR is increasing, but because of, again, these changes in testing, the actual outbreak may not itself be increasing. And we simply, again, don't know. And then worst of all, we could observe a decreasing TPR, but actually an increasing outbreak because of a massive expansion in testing or changes in who is eligible for testing. So we don't like TPR. We can see weird things like TPR decreases during the holidays. Really? I don't think so. But while other more reliable indicators are more steady. So again, TPR is bad. We don't use it to interpret epidemic trends.
Okay, so not only is TPR bad on principle, it also doesn't work. So this is a plot from Phil Arevalo, who's really the person driving modeling in my group. He's an amazing postdoc. And what we're looking at here is the lead time of the test positivity rate relative to those admissions with COVID-like illness, which we know are a really good proxy for who's showing up in the hospital with COVID. And so you can see sometimes it's leading, sometimes it's lagging, and the correlation is all over the place. And these trends are varying pretty dramatically over time. So it's really not a great metric to be hanging your hat on.
So what are better metrics? I'm going to walk through a few examples here using this kind of cartoon time course of someone's journey through COVID. So we know from exposure to symptom onset, that's about 6 days. And from symptom onset to death, it's another couple-ish weeks. And then from death to your death being reported is another like nebulous time, somewhere between 7 to 14 days. Like this cartoon from CDC said 7 days, but from our look at IDPH data, perhaps it's closer to 14 days here. So even though death is a really reliable thing, like, it's pretty unambiguous whether or not someone died, and whether they died of COVID is, also fairly unambiguous. This metric is way too lagged to give us kind of a now picture, now situation awareness of what's going on, today. So hospitalization is a little bit less lagged, since you enter the hospital typically before you die, or you may not die after after your trip to the hospital. I don't want to insult any kind of like COVID physicians here, but there's still quite a bit of lag between the exposure event and your admission to the hospital. And that lag can be pretty varying because of different courses of illness. So ideally, what we might want to say is like, look at cases. So cases themselves are the raw numbers are hard to interpret because the data is reported in the aggregate. So it's people who, showed up at the ER and got tested for COVID. It's people who like didn't feel good and got outpatient testing. It's people who were tested routinely as maybe part of their employer or university testing. So all those data is kind of together. But, if we just kind of think, well, how about those people who are feeling mildly symptomatic, so having some cold or flu symptoms, and they're getting tested, perhaps we could have a more like rigorous understanding of the time between their exposure event and then when we got information about their test results. So we know from data gathered throughout the year that the time between symptom onset and getting tested is somewhere between like 0 to 6 days. Sarah's Illinois study had seen perhaps 7 days. We think maybe it's a little bit shorter now. It's a little bit unclear. And then the turnaround time between testing and getting that result used to be super long. I think we've all heard stories of people waiting, 2 weeks, 3 weeks for their test result, particularly about a year ago. Now it's like gotten a lot better as capacity has increased. So what we're thinking is, like if we actually collected this data on, how many days ago did you start feeling sick and what was your test turnaround time, which actually is already collected. If we were able to collect this data on between symptom onset and testing time, then we could actually infer people's date of exposure, because that time between exposure and symptom onset is actually fairly consistent. But the issues are that first of all, whether or not someone is symptomatic is not systematically collected everywhere in the state. And even if that is, the time between symptom onset and testing is not always collected. And then on top of that, even when this data is collected, the data doesn't automatically get reported to our public health entities. So that is, kind of more of like an IT or legal data transfer barrier. But, in theory, if we could kind of minimize those two lags, we could be inferring things like RT with as little kind of history as possible. So we would be looking as closely into the past as possible to infer RT without doing something like very large scale and systematic, like random testing of people, regularly to measure prevalence. So this is what Sarah and I proposed in early May of last year, that we would use what's called surrogate populations to track RT. So, and we want these populations to be very consistent. That's kind of the key, to have them be consistent through time. So we proposed, identifying those people who are coming in for testing in outpatient settings. figuring out which ones of those were symptomatic, who had recent symptom onset, again, so that we look as closely into the past as possible, and to track basically the prevalence in this population, and say that, that's not going to be the same number numerically as the prevalence in everyone in Illinois, because it's going to be higher. These people do have symptoms of illness. However, the increases in prevalence in this sentinel population should be reflecting increases in prevalence in the population at large. So that's the central assumption. This idea of sentinel surveillance is not new to COVID. It happens in flu, it happens in other diseases where you have kind of an easier access population, where you say, trends in this population are reflective of trends in the general population. And then in addition to this kind of core focus primary group of symptomatic people in outpatient settings, we also proposed 3 additional groups. One, pregnant women pregnant individuals presenting for labor and delivery, a lot of whom were already receiving universal testing at the time, and a couple of other groups. Sarah, I think this one is you, right?
Sure. Yeah, I'm happy to talk about this. Okay, so Jaline and I have been, I guess we started formally really pushing for sentinel surveillance in mid-May, actually, the one component of the sentinel surveillance, again, this labor and delivery population, was set up pretty quickly. So we had a brief already for Pritzker on August 7th. We didn't get the outpatient sentinel surveillance. That had a rocky start, really going until August, and then it was expanded over the next couple months. We produced a report. We have produced a report on outpatient sentinel surveillance data. We discontinued the labor and delivery sentinel surveillance in January. I'll show you why in just a bit. Jaline has recently become involved with the Chicago Department of Public Health and is beginning to explore outpatient sentinel surveillance for them. All right, so what happened with labor and delivery? The reason we were inspired to look at this population is it's relatively invariant to, interest in getting tested for COVID. These are people who are pretty much going to the hospital on, a certain schedule that they don't completely determine. So we thought that they would be a fairly reliable denominator. Disadvantages, of course, is a smaller population, but we were also excited about them because they had been shown in New York City to reflect really well what looked like differences in infectious disease burden in different boroughs, and also changes in infectious disease burden over time. But we were surprised to find, again, so we're looking here at a different period than, of course, the first wave of the pandemic, where they had been shown to be good sentinels effectively in New York City. What we found is that they did not track hospital census populations, which we're using as our proxy for COVID burden, very well at all. This is kind of reassuring because it does suggest that maybe pregnant women are taking precautions that are reducing their COVID exposure, but it's obviously not great if we're trying to use them as a barometer for prevalence, or I should say RT in the general population.
So we are seeing a lot better promise in the outpatient sentinel surveillance. This is data coming from CDPH. In the blue, we have the COVID-like illness admissions. That's kind of our gold standard. And then in red, we have sentinel cases here. This data set, unfortunately, doesn't have a denominator. So it is vulnerable to fluctuations in testing, which is, I think, what's happening in late November. So people stop coming to testing because of Thanksgiving. But what we're seeing is that there is a lead time of 14 days in the sentinel cases relative to the CLI admissions for that fall wave. So then in theory, if we'd had this surveillance system up and running in September, we would have been able to be confident 2 weeks earlier that we were seeing a true resurgence in COVID. And that would have allowed us to hopefully act for 2 weeks earlier and really mitigate some of that huge resurgence.
So, taking a step back, one of the aims of estimating RT was to understand how changes in policy, for instance, social distancing, or what the degree of dining that was permitted indoors, how that affected transmission. So basically to be looking at correlations between shifts in policy and then shifts in the reproductive number. So what we're looking at here are different, it's okay if you can't keep them straight, but basically different policies, tiers, phases over time for the whole state, and then just for Chicago, which might be easier for some people to recall. So as we mentioned, we had a huge decline in the reproductive number, which you could see because, hospitalizations were plummeting eventually during shelter in place. And we did see an increase in the reproductive number as shelter in place was released. But then after that, and this holds true when you look at the different COVID regions with Illinois, we really don't see a strong correlation between the onset of some policy change and some change in the reproductive number. And we've looked at a lot of different things and are continuing to look at a lot of different things, especially mobility metrics, to try to find predictors of changes in RT. And so far, really, we haven't come up with anything. So this is very interesting and is probably going to inspire many PhD theses. All right, so the next topic we wanted to cover is vaccination rollout. Just going to say a couple words about this. First thing to do is to look at the plot on the left. So here we're looking at the per capita risk of hospitalization in different age groups relative to 50 to 59-year-olds. So they're at 1, they're that horizontal dark blue bar, and the curves above that are older age groups. And so you can see that we have had a recent decline, especially in the oldest age groups, 80 plus, in their relative risk of hospitalization. I think some of this is too early to attribute to vaccination, by which I mean the decline is happening a little too soon, but almost certainly some of it is due to vaccination. This is something that we are trying to analyze more carefully. But again, stepping back even further, the way that we rolled out the vaccine is very generally, in line with principles that a lot of scientists have converged on, which is that we know that the greatest risk of severe illness and death is very strongly associated with age. And so if you're trying to maximize the benefits of vaccination, we can think of that as like minimizing hospitalizations and deaths, then we should be rolling it out in a way that is like quite age structured, or at least ideally structured according to greatest risk of severe illness. However, it's also obvious we have a vaccine shortage right now. And given the restricted supply of vaccine, I think there's really, really strong epidemiological evidence. There are a lot of models published on this, showing that in that sort of situation, you should be doing something called dose sparing, which is that, for instance, if you can, instead of giving 2 doses to one person, give 2 doses to different people, and they're each protected at least half as well as the person who received both doses, they're going to save more lives if you spread out the vaccine. Yeah, so I think that was a missed opportunity. It was something that was definitely being kind of dismissed at the national level for a long time. So it's not hard to see why Illinois, was not in a great position to do something different here. But I think it's a sad decision that's cost a lot of lives. We've also continued to see huge racial and ethnic disparities, in this case, in access to vaccination. And there's a great article in the New York Times this morning about that, if you want to read more. And another factor that we're discussing, that is the modeling teams, is as hospitalizations fall, we're going to need more robust data sources to get the same level of statistical precision about what the reproductive number is doing. So we still need to improve surveillance. Couple words too on variants of concern. So I'm talking about B117, B1351, P1, doesn't matter. Variants of concern that are either spreading fast and or show some degree of ability to escape antibody responses, neutralizing antibody responses. So there have been some really nice papers showing that at least B117 has huge transmission advantages, might be spreading at least, half or 50% faster than the kind of wild type or other variants, or I should say the non-variants, whatever we refer to general SARS-CoV-2 as. So when you have a fitness advantage that's like that big, and we already have appreciable frequencies of B117 in the world, it means that the spread of B117 or of variants that are phenotypically like similar to it is completely inevitable. And so that means genomic surveillance to figure out if the variants are going to be here and like what their precise frequency is it's a nice thing to know academically, but I don't think it should, it's not something that our public health response should depend on. So I think the priority right now should be to be identifying transmission hotspots, reducing prevalence. So that would involve increasing mitigation. And again, if we're interested in reducing prevalence fastest, then we'd be prioritizing first doses rather than making sure that we have second doses lined up for everyone on the original FDA schedule. But there are major sources of uncertainty in our projections. We had this same source of uncertainty with the release of shelter in place. That is, we still don't understand exactly what the seasonal drivers of transmission are really for any respiratory pathogen. So it's really unclear how much that is going to be slowing the spread of these otherwise more transmissible variants. Vaccination coverage is obviously going to have huge impact on who's showing up in hospitals and dying, and there's also really strong evidence, of course, that there are indirect benefits from vaccination and that it's reducing your probability of transmitting to others. And we still don't know how to model human behavior in a really great way.
All right, then kind of looking forward from here in the kind of next pandemic framework. So what we really think is so critical is just understanding where you are in the first place. Like, forget where you're going, just where are you? And this idea of sentinel surveillance, like, we think is, in theory, fairly straightforward. It's surveillance that's already happening. It's syndromic surveillance that's already happening. Can you just kind of slice and dice the data in a different way to give you a more rigorous idea of trends? And at a statewide level, even within Illinois, just looking at Illinois is not enough. And one of the things that we run into modeling Illinois is Southwest Illinois, the East St. Louis area, like to what extent people go and seek care in St. Louis, so across state lines. And we have, very limited data visibility into what's going on in Missouri. And so that's, a population that is kind of, hidden to us. And that's not the only state that we border. And so having a national or federal surveillance system, such as, ILI, the influenza-like illness, ILI-NET, is so critical so that all of us who are interconnected can really understand the interconnected situation that we are in. And again, standardization is also very important, because without standardization, how are you going to compare across time if your standards are changing, or across space if standards are different across different states? In terms of basic epidemiology, just being able to understand how the infection has moved. So a lot of people have looked at proxies for infection movement by looking at these kind of mobility data sets coming from Google and Facebook, et cetera. But to what extent does human, actually cell phone mobility, actually mirror the movement of pathogens? It's a big question in malaria. It's also a big question here, right? Because obviously the cell phone isn't carrying the infection. And if if I'm moving around but wearing a mask, doing social distancing, that's different than from someone who is not, but may have the same cell phone pattern. So the gold standard way, one of the gold standard ways to understand this is genomic surveillance, where you can understand, from phylogeny, where the infections came from and where they have spread, and whether you're importing, whether your circulation is really local. So that's all really very important stuff that we completely, I think, don't have the infrastructure to ramp up very quickly in response to a surprise pandemic. And the other really great thing that would have been so awesome to have is a representative cross-sectional seroprevalence study. So understanding like who actually has been infected, what fraction of people that is, whether that's different across demographic groups, so key. From a modeling standpoint, like we are guessing, that a certain fraction of Illinois population has been infected, but it would be nice to have some ground truth to be more confident in our models or to make changes. And having this kind of estimate of the fraction of people who've been infected, lets us evaluate whether we did a good job on the interventions that we did do, or were there certain populations that we systematically missed. And the same with the diagnostic testing, does our diagnostic testing data actually reflect kind of more of a truth that we would see through seroprevalence studies? And it's not super easy to do these seroprevalence studies in a representative way in this country. And that's a big challenge that I think people really need to figure out, how to do this in a representative way with a really fast turnaround so that we have timely evidence that we can act on. And then let's just move on from here. So from an intervention standpoint, like what could we do better next time? The first thing that really comes to mind is the messaging that we as a scientific public health community have been distributing. So as we know, there's been all kinds of mess ups in terms of the messaging around PPE, around testing, et cetera. Like, come on, like, I think we have the expertise here to craft our words in a better way. Obstacles to compliance. What were they? There were economic obstacles, there were other obstacles. You know, if you don't help people make the decisions that will help the population, then people are less likely to make those decisions. So whether this is, you know, a monthly cash stipend for people who are out of jobs or whatever, whether it's supplying adequate PPE, come on, like this is something that really should have happened. And again, this is not so much of a state failure, that a lot of this was happening at the federal level. This is an ongoing conversation in infectious disease, you know, what benefits the population versus what benefits you yourself. You know, I think about this with the vaccine rollout, you know, from a personal standpoint, boy, would it be great for me to get vaccinated, but from a population standpoint, boy, would it be great for someone who's more at risk and older to be vaccinated. That's a very simple, immediate example, but there's all kinds of decisions that we made as individuals during this pandemic that impact the population. Cost effectiveness was something that didn't really come up, surprisingly, in any of our conversations. We were very surprised about this, especially around contact tracing, when it was incredibly obvious to us in kind of mid to late April last year that contact tracing was just going to be $250 million flushed down the drain. And could you like spend those dollars on things that would have had a larger impact? Possibly. And then lastly, and this is to the point Sarah made earlier, in that changes in RT don't obviously track changes in like our progression through tiers and phases, is that like we have not measured to what extent people have complied with these tiers and phases. And so we don't actually know what interventions have in effect been applied. And if we don't know what has been applied, there's no way we can understand why our policies are or aren't working.
Okay, so to leave time for questions, I'm just going to touch on these points quickly. I think it's probably obvious to everyone here that the national pandemic response is messed up, partly because we've been underinvesting in public health. And so that obviously includes public health knowledge and capacity. One of the things that I'm just gonna say surprised me was how often, and some of this is my fault, like I had not previously reached out to the Chicago Department of Public Health, IDPH, other local organizations, but it was surprising to me how often management consultants were brought in to address what are, you know, scientific questions that there are multiple people in the state, you know, thinking about these issues like from day to day. And there's a lot of specific expertise that is relevant to lots of these policies that I think was not recognized, especially early on. And that's kind of normal for an emergency situation, but we should do better in the future. This is also a little more general. It's important not to conflate specificity of evidence with the strength of the evidence or exaggerate evidence base. So for instance, there's a lot of caution about deviating again from like the clinical trial protocols with vaccinations. And I think this is a more philosophical discussion. I think overemphasis on exactly what constitutes a close contact, in spite of very little evidence. There should be more quantitative training, refreshers, you know, on areas that people are pulled into that they might not normally work on. Data handling and processing needs to improve. There's found lots of problems with compliance, lags quality of the data. We could be improving workflows to minimize the reporting burden on hospitals, which has been terrible. And I think also it would be good to try to err toward more sharing in emergencies. And so all this comes down again to investing in public health.
So to kind of close conceptually here, we want to say like, what from the eye of what would we do better next time. And I think it makes sense to prioritize those people who are most vulnerable, whether whatever category they're in, because the things that we do to keep them safe and healthy are going to be the same things that we do for the whole population. And once we've kind of, address the most vulnerable populations, which typically are a little bit more difficult to do things well in, then we know how to do things well for everyone. So just kind of thinking through this, for essential workers who need to remain active and mobile through the pandemic, we need to have excellent prevention. For people who live in congregate settings where an outbreak can be particularly devastating because contact rates are so high, we need to have excellent surveillance, and we need to act quickly, and we need to act effectively, and we need to know what those responses are. For people who are lower income, we need to provide sufficient economic support so that they can make the decisions that benefit the public. And then we need to remove those obstacles to compliance, especially if they're economic. And for communities of color who've experienced long-standing structural racism and barriers to access to quality care and quality interventions, we need to prioritize having high intervention access for them. We need to prioritize community engagement so that intervention can be uptaken quickly and thoroughly. And the idea is, if you have all of these pillars in place, you are going to have population benefits for everyone, both in terms of everyone being able to access all of these different structures that you've built up, but also infectious disease is infectious, right? If we lower transmission, that's something that has knock-on effects. Let's just quickly go ahead and plug our website.
Go ahead. Hey, thank you very much. Wow, that was incredible. There's a lot of questions here, and we're not going to be able to get to them, just a few. So if you could give some just concise answers. Here's one: 30% of the COVID patients are asymptomatic, but able to transmit. How does this fit in the model?
We include that in the models. It's very tricky, of course, to track that population without good seroprevalence. We don't really know, honestly, if it's 30%, but it's probably something kind of like that, but that's in the models.
Okay. One person said, did I hear you correctly that only the shelter-in-place policy was correlated with a reduction in cases?
Yeah, with an obvious one, with reduction in transmission. I mean, generally, to show correlation, you need to show, something multiple times. But yeah, otherwise we didn't see things really lining up that well. Still working on it, but
we're a little shocked about that answer, right? What about the theory that only giving the first dose of the vaccine could lead to a greater chance of resistant variants emerging? I'm not sure you really touched on that, really.
I have a preprint out on that, actually. It's on Dash. If you look at my recent Twitter profile, I discussed that. I don't think I actually think dose sparing and expanding coverage would actually reduce the rate of antigenic evolution.
You said that it would what? Say the
reduce the rate of antigenic evolution, so actually be beneficial.
It would be beneficial. Great. Have you looked at the sentinel surveillance among children?
Well, an issue with children is that they are tested the least amongst all the age groups, but don't have the lowest test positivity rate. So it is possible that especially older children, so children 11 through 18 or so, could be a good sentinel population. If there is easy access to this group, I think it could be great. I'm all for it. More data is better. More testing of children is better. Let's please test children more.
Yeah. Last question, and I'm sorry I'm not able to get to all of them. Have the models been able to predict the second wave, say back at the end of the summer? What magical ingredients created the second wave?
Magical ingredients were us not doing anything to prevent it. And I think that there's a few things that we don't know. So for example, is colder weather, does that mean better transmission for the virus on a biological level? Does colder weather mean that we're all kind of hanging out indoors and coughing on each other versus hanging out outdoors and coughing on each other? And that would have, this 20 times higher transmission indoors versus outdoors. Was that it? But again, we don't have the data to actually, I think, understand this because we don't know what people actually did. And so we can't really even infer whether things are correlated, much less causative.
Great. Hey, I'm sorry, we're not able to get to the other questions. You got one very nice comment too, but nice to see collaboration between two great academic institutions. So thank you for that. And thank you both again for taking the time to share your insight and experience with us today. Thank the audience for coming, for your thoughtful questions. I'm sorry we didn't get a chance to get to all of them. Also for April, our first Friday webinar series we will be joined by Jose Ramon Fernandez Peña, Director of the Health Professional Advising at Northwestern University and President of the American Public Health Association. So again, we thank you for joining us today. And for those of you that have registered, a recording of the webinar will be shared via email shortly. And this concludes today's session. Thank you very much again.